Good evening, ladies and gentlemen. And as we speak tonight, the government is back in business. And the hang-up at the time was over the Affordable Care Act. And they're still thrashing at it, as far as I understand it. Not sure what the results are going to be. But on the other side of the game is, what are we going to do here locally here in Massachusetts? So this evening we got with us tonight Bob Mason. Welcome, Bob.
Thank you, George. It's good to be here.
You're an advocate for mass care.
Mm-hmm.
So what's mass care?
So mass care is an all-volunteer grassroots organization that's been around for about 30 years that's been promoting Medicare for All Massachusetts legislation in the State House, sometimes referred to as single payer.
Yeah. So this would be an alternative to the federal Medicare and people's individual insurance, medical insurance, either through the company they work at or guys like you and me that are retired that would depend on Medicare itself from the federal government.
Well, so there are two possibilities with this. The idea is that Medicare for All Massachusetts, sometimes referred to as new and improved Medicare, because it covers much more than traditional Medicare would cover. There are two ways that could work. One is that the federal money that flows into Massachusetts for Medicaid, Medicare, and a few other federal programs would go to a health care trust that is established by the legislation, and that would pay claims for the health care that every resident of Massachusetts would receive throughout their lives. So it would be what's called one payer or single payer. Now, if the administration, let's say that in Washington, was not favorable to this, then the second option is that people would still receive their traditional Medicaid or Medicare or other kinds of federal health insurance, and then Medicare for All Massachusetts would wrap around that to ensure that no one would have any out-of-pocket costs.
Yeah. So I guess you guys have done some research, and I guess you put up the first chart, Chris, if you would. And what'd you find out?
So Massachusetts, in many regards, has one of the best systems in the country in the sense of a very low uninsurance rate. And that chart shows that it's 1.7%, at least when this study was done back in 2023. The problem is that many people who have insurance in our state find that actually using it is difficult to afford. And there are several reasons for that. It may be that they have substantial premiums they're paying for their insurance. It may be that they have a large deductible that they have to pay out of pocket before their insurance kicks in. It may be that they have co-pays or co-insurance that also adds to the expenses that are coming out of their pocket.
Yeah.
And so, unfortunately, there are a good percentage of people who don't seek medical care or don't fill prescriptions because they can't afford the out-of-pocket costs.
Yeah. Well, that second number up there, that 41.2%, that to me seems to be a problem that basically the medical system can't handle all the people that need the help, because you want to get an operation, you got 3-4 months delay before you can actually get the slicing and dicing done. And there's a couple of problems involved in that I've run into. One is that trying to get medical coverage, trying to get an appointment with somebody, it's hard to come by finding a doctor, especially primary care doctors. They're few and far between, and very few are taking new patients. And the other issue you get into is most of the surgeons run into problems that they can only get so much operating room time because there's more surgeons than there are operating rooms. So we've got two basic problems that I see in the system is lack of medical teams and also the lack of facilities. So how does this program address that, or does it at all?
Well, so it addresses different aspects of that problem. So one thing you pointed out was the problem getting a primary care doctor or a primary care appointment. And what we're finding is a large percentage of primary care physicians are retiring, and those that very basic specialty is not being filled by up-and-coming doctors. And one of the reasons is burnout, because there is so much involved in being a doctor these days, dealing with pre-authorizations, dealing with different insurance companies, dealing with very limited amount of time that they can spend with patients. So on the one hand, for primary care doctors and other doctors too at times, their work life has become much more stressful. So then you don't have enough, at least primary care physicians, coming on board. The other problem is that in any state in this country, there are what you'd call healthcare deserts. So when you have a large city like Boston, you may have lots of healthcare, but when you go to rural areas in any state, in our state too, you don't have enough doctors. You may have hospitals that are too far apart to attend to urgent needs that residents may have. So what MassCare's legislation, or the legislation we support that's been introduced in the State House and State Senate does, is that the healthcare trust looks at all the healthcare needs across the Commonwealth, and when they make budgetary decisions about financing hospitals, they look at where are the needs across the state and where should we invest that money so that we more equitably meet the needs of residents. So it's really coordinating the whole thing.
Okay. And I guess the next chart you brought on is how do we finance this thing? And one of the issues you brought up, I think, is that there's an awful lot of money being spent on medical, not too prudently, let's put it that way. And we've all remembered the case of stewards, several hospitals that they so-called managed, and they managed them into the ground. So that, there's a lot of slop in the system and a lot of questionable expenses. Is that going to be enough to make a difference?
Well, it is. That's what our economic impact studies have shown over the years. Gerald Friedman, an economist at UMass Amherst, has studied this issue for a number of different states and federally, and determined that a significant amount of money can be saved with this model. So right now, with the current so-called system, and it really is a very fragmented, complicated system, 30 cents out of every healthcare dollar goes to administration, salaries, and if it's either a profit-making hospital or medical practice, et cetera, goes to profits and sometimes goes to excessive CEO salaries.
Yeah.
So
You
there
got
is a
another
lot of
chart
that.
on that. Chris, if you put up the next chart, please. Yeah, those are the kind of numbers that you were mentioning, that it gets to be kind of a lucrative business to run a hospital.
Well, it becomes a lucrative business, even nonprofits.
Yeah,
They're also paying for advertising. They're also paying for lobbyists.
yeah,
And if it is an insurance plan or a hospital that's there to make a profit for shareholders, their first responsibility is making that profit. It isn't caring for patients.
yeah. So we get down to the basic question, how does Mass Health for All really work?
So there are a number of steps that would occur. So one of the things is the legislation would establish the healthcare trust and the administrative structure.
Yeah,
And so, as you can see from the chart, currently multiple insurance companies take a profit. With Medicare for All, instead of healthcare being a profit center, healthcare being an investment for profit, it would be an investment for healthcare. There would be global budgets for hospitals and nursing homes, like the fire department. There would be fee schedules for individual clinicians, and price controls for drug companies, no out-of-pocket expenses for patients, free choice of doctor, clinician, and hospital, no prior authorizations required, and actually there would be the ability to increase the reimbursement rates for primary care physicians, which are really the lowest paid doctors in the healthcare system.
so when you talk about this different fee systems, is it going to turn into a system whereby the doctor is paid so much per hour, so much per day, as opposed to so much per patient?
So primarily there are a couple of ways that would work out. So for physicians, let's say in a primary care office, they would be paid per service rendered
Okay,
to a patient, per appointment and what type of service is provided at that appointment.
yeah,
If it were a hospital system, it may be that they would operate under a global operating budget for the year, and there would be adjustments made at the end of the year. If they received more money than the services would account for, then they would refund the healthcare trust the excess.
Mm-hmm.
If they actually spent more money providing services than were determined to be anticipated by the healthcare trust, they would get some additional reimbursement, because sometimes hospitals or clinics are in areas of the state where perhaps they're providing care for people who have reduced income.
yeah.
So that would, there would be adjustments made.
Well,
for
then
that.
again, you can't tell when the next COVID pandemic is going to break. It doesn't necessarily have to break
Right.
on the 1st of January, so you can account
Right.
for it in the whole year budget
Yeah.
kind of thing. So I get into some of these issues that it's going to be a little difficult, I think, to make this transition to a different system. And the other thing that comes out of you talking about no out-of-the-pocket expenses, and yet the next chart will show us that you have this particular scheme of how you're going to finance this thing. and I went through some numbers on myself, and for my wife and I, we're spending in the order of $11,000 a year on medical expenses between the fees for Medicare, co-pays, and the co-pays for medicines, and it mounts up. And I'm starting to wonder, when you look at the schedule that you have, I don't see where that's going to come up with enough money to finance the system.
Yeah.
So I guess the thing that's missing in my mind is where are all these savings coming from?
So you'd actually, it would help to look at the economic impact studies that have been done. And you can do that actually at MassCare's website, and it shows exactly where the savings are coming from. One of the things is, again, right now, 30 cents out of every healthcare dollar does not go to actual healthcare. It goes to administration, goes to profits, it goes to sometimes excessive salaries, and it's administration on both ends. It's not just with insurance plans, but it's also the administration in the doctor's office. So that's a huge amount of savings right there. And the economic impact studies show that for the most recent one, that Massachusetts could save $37 billion over what we're paying now for health care coverage. Now, you can see from the chart that what takes the place of premiums, co-pays, deductibles, co-insurance is a payroll tax or a self-employed tax, etc. And the chart shows the specific percentages, excluding the first $20,000. And it doesn't include Social Security, SSI, unemployment, etc. There are certain income sources that are not tapped for the revenue to support this. And again, the studies show that about 98% of residents in Massachusetts will pay less, and in some instances far less, for a lot more coverage.
Yeah. That sounds miraculous. That's part of the problem that we got into with the federal government level, because the Affordable Care Act, sometimes called the Obama Act, was going to save money. And the problem is it didn't save money, it cost more. And so therefore they came up with, okay, we'll have a supplement. And they're supposed to get us through the COVID time period. And then when that didn't happen, that they still needed the supplement after COVID, that's when difficulty became. I can express it more succinctly in words of one syllable and 4 letters. That'll get me shut down. But that's where the difficulty came in between the two parties, and they went to loggerheads, and they just could not agree. And I keep thinking in the back of my mind that this is going to be a challenge with any government program, that you start off very optimistic that, oh yeah, this is going to be great, and then reality hits, and all of a sudden different expenses show up. And one of the points you were making earlier about the doctors, primary care doctors especially, being bogged down with a lot of paperwork. I can't remember the last time I sat with a doctor like we're sitting, just talking. The doctor's on the computer typing in the minutes of the meeting, of the discussion of what's going on, trying to get all this stuff done. And I guess that's the other thing that bothers me is, how do we make sure this thing really works?
Well, it has worked in many other developed countries that are similar to the United States in terms of being high-income countries. So that's one thing. So it's not as though it hasn't been tried. Now it varies, the specifics of the model from country to country, whether it's France or it's Great Britain or Canada, etc. And there's no absolute perfect. It depends also on changes in the government that is in power at any particular time and how well they finance a system. But when you look at, let's say, the Affordable Care Act or Obamacare, that was not a single-payer or Medicare for all system. It still had a lot of the problems that have led to unmanageable costs for both, for individuals, for municipalities, for businesses, etc. So there was no way that the Affordable Care Act was going to manage costs and expenses. What it did is it expanded the number of people who had some sort of health care coverage, and that was important. That was an improvement, but it wasn't really designed well to manage the overall cost and efficiency.
Well, one of the things that keeps coming up is short blurbs that show up on the email about I took the trip to Canada and I had this problem and I needed 14 stitches and they took me right away and sewed me up. And when I checked back in the United States, the doctor said, geez, it must have been some sort of fancy surgeon that did this because there's no scar from this. And then it goes on to say, but the natives have a heck of a long wait if they want to get to a doctor or get service. And there's been stories around about citizens of Canada coming across the line and just buying their way into medical coverage in the United States just to get the coverage in a reasonable period of time. So there's always going to be that problem that the more people you get involved in the system, the more people are going to look for services. And right now, as far as I can tell, the system is really bogged down with how much capacity they have to treat the customers that need help. And like I said, it takes 3 and 4 months to get to a surgeon to do an operation, and they're all tied up. So this problem is still going to be there, I think. This particular program doesn't solve that at all, or doesn't work on it, does it?
So one of the ways that it works on, I mean, those are very important questions, right? And they trouble most people. Sometimes you hear anecdotal kind of statements, stories, et cetera. They may not actually be backed up by the overall statistics, but nevertheless, they're of concern to anybody. So here are a couple of ways that this kind of model improves the care. So one of the things is that number of years back, when studies were done on how much time does a doctor spend seeing patients and how much time does he or she spend on managing documentation for insurance companies, maybe being on the phone to try to get an authorization appeal approved, etc. And it showed that in an 8-hour day, a doctor may spend 2 hours managing all that paperwork and the phone calls. Under a single payer plan, the doctor won't have to do that. There won't be pre-authorizations required. We'll trust the doctor. They won't have to deal with multiple insurance plans, maybe 400 different kinds of plans. They won't have to fill out all that paperwork or documentation on a computer, certainly, not necessarily old-fashioned paperwork, but nevertheless, all of that administrative work that doctors have to do now will be eliminated. So they'll have more time for patients. The other thing is, it tends to be a system where doctors have a better quality of life. They're less stressed. They're less likely to feel burnout. So it'll be more attractive to go into the profession. So that's the other thing. Right now also we don't have enough other kinds of healthcare providers, nurses, nursing assistants, etc.
It's the whole system.
Yeah. So this plan could expand the number of people who go into that kind of work versus the number of people who are tied up managing insurance claims.
So I guess the issue comes down to you've been advocating, this organization you're a part of has been advocating for like 30 years to get something to happen. It hasn't happened yet. If somebody wants to get involved, how do they help out?
So there are a number of ways they can help out. Let me tell you a little bit about where the status is right now in terms of the legislation. It's in the Joint Committee on Healthcare Financing. And for it to come to the floor for an eventual vote, it has to be reported out favorably by that committee. And that committee has received an extension for their work until I think it's early March of 2026. This legislation has never made it out of committee. Mm-hmm. What people can do if they're interested in supporting this and at least having it brought to a vote on the floor, they can contact their legislator. Now, we're very lucky here in Beverly. State Representative Hannah Bowen and our State Senator Joan Lovely are both co-sponsors of this legislation.
Oh, okay.
And so certainly calling them and letting them know we appreciate what you're doing. What else can we do to support you in what you've are co-sponsoring? That's one way. Another way is that some municipalities are looking into passing resolutions to support the legislation. And for example, on Cape Cod, there is I think it's called the Barnstable Legislative District. It's a little bit different formation of municipalities there. Recently passed a resolution to support the legislation, so it increases public pressure on the legislature to get it moving on considering this legislation. Another thing people can do, they can go on the MassCare website and you can sign a petition. In January, some of us will be going to the State House and presenting the petition to the chairs of the Joint Committee on Healthcare Financing. Again, to show them there's public interest in this.
Okay. Well, thank you very much for joining us this evening. And ladies and gentlemen, as mentioned always, if you've got a comment, send me an email. Or if you've got a longer comment, there's room for you here at the table. And thanks for watching, and stay tuned. We'll be back.